Hi, welcome back to your prescription for medication education. My name is Yemi and I'm a pharmacist and I enjoy talking about medications. And if you like learning about them, guess what? Then this is the right channel for you. Today I'll be talking about hydralazine, minoxidil, and sodium nitroprusside. So let's begin. So at the beginning of the video, I always like to start off with 5 questions, and then by the end, you should be able to answer all 5 questions without any issues if I've done a good job. So I'll go ahead and read off questions 1 through 5, and at the end, I'll go ahead and provide the answers. Question number 1. A 58-year-old patient with resistant hypertension is started on minoxidil after inadequate blood pressure control on multiple agents. 2 weeks later, he reports a 6-pound weight gain, ankle swelling, and a resting heart rate of 108 beats per minute. Which of the following is the best recommendation to reduce the predictable adverse effects of minoxidil? Is it A, add verapamil and acetazolamide, B, add a beta blocker and a loop diuretic, C, add clonidine and spironolactone only, D, discontinue all background antihypertensives and use minoxidil monotherapy. Question number 2. A patient receiving sodium nitroprusside for hypertensive emergency begins requiring progressively higher infusion rates to maintain the same blood pressure response. Shortly afterward, the patient develops confusion and tachypnea. Which of the following is the most likely explanation? A, thiocyanate toxicity causing early ototoxicity. B, reflex sympathetic activation from venous dilation. C, cyanide accumulation causing tachyphylaxis and impaired oxidative metabolism. Or D, methemoglobinemia causing isolated hemolysis. Question number 3. A 63-year-old patient taking hydralazine for hypertension develops palpitations and worsening exertional chest discomfort shortly after a dose increase. Which of the following best explains these adverse effects? A. Hydralazine causes direct AV nodal blockade, reducing coronary perfusion. B. Hydralazine causes arterial vasodilation, triggering baroreceptor mediated sympathetic activation. C. Hydralazine causes marked venous dilation, reducing preload and coronary steal. Or D. Hydralazine inhibits myocardial calcium influx, leading to negative ionotropy. Question number 4. A 46-year-old patient with alopecia is taking low-dose oral minoxidil 2.5 milligrams daily and asks about a common cosmetic adverse effect. Which of the following is the most accurate counseling point? A. Hypertrichosis is unrelated to dose and usually starts after 6 months. B. Hypertrichosis commonly begins in the scalp only and is permanent after discontinuation. C. Hypertrichosis is dose dependent, often begins within 3 to 6 weeks, and may improve after stopping therapy. Or D. Hypertrichosis is a sign of cyanide accumulation and requires urgent discontinuation. Okay, and the last question, question number 5. A patient with pulmonary arterial hypertension is taking Riociguat and presents with severely elevated blood pressure requiring IV therapy. Which of the following agents is contraindicated because of synergistic effects on the nitric oxide cyclic guanosine monophosphate pathway and risk of profound hypotension? Is it A. Hydralazine, B. Minoxidil, C. Sodium nitroprusside, or D. Labetalol? In this video, I'm going to focus on 3 important vasodilators that are used in hypertension: hydralazine, minoxidil, and sodium nitroprusside. But before we review each individual medication, let's do a quick review on preload and afterload. Preload and afterload describe 2 different parts of ventricular function. Preload reflects end diastolic ventricular stretch, in other words, how much the ventricle is stretched at the end of diastole, which depends on how much blood fills the ventricle before it contracts. It can be clinically estimated using end diastolic volume or filling pressures such as left ventricular end diastolic pressure or pulmonary capillary wedge pressure. Left ventricular end diastolic pressure is measured directly during a left heart catheterization by placing a catheter in the left ventricle, while pulmonary capillary wedge pressure is obtained during a right heart catheterization by advancing a balloon-tipped catheter into the pulmonary artery and inflating the balloon, which estimates left atrial pressure, which approximates left ventricular filling pressure. Afterload refers to the forces opposing ventricular ejection during systole. It represents the total myocardial wall stress during systolic ejections. In simple terms, it is the load the ventricle must overcome to push blood forward and is influenced by systemic vascular resistance, arterial compliance, and reflected pressure waves. Vasodilators can be divided based on where they primarily act. Vasodilators can predominantly act on capacitance veins, which causes blood pooling in the peripheral venous system and reduced venous return to the heart. This results in decreased preload, decreased cardiac output, decreased stroke volume, minimal reflex tachycardia, and reduced myocardial oxygen demand. A primary example is nitroglycerin at low to moderate doses. Vasodilators are useful in the treatment of pulmonary congestion and acute coronary syndromes. Vasodilators can also predominantly act on resistant arterioles, reducing systemic vascular resistance. This results in decreased afterload, increased cardiac output, increased stroke volume, and more pronounced decrease on diastolic blood pressure compared to systolic blood pressure, increased in reflex tachycardia, and increases in renin-angiotensin-aldosterone activation. Hydralazine is an example of an arterial dilator. Vasodilators can also be considered mixed dilators, which produce a balanced reduction in both preload and afterload. This results in decreased left ventricular filling pressures due to the venous effect, increased cardiac output due to the arterial effect, and result in some reflex tachycardia. Sodium nitroprusside is the prototypical mixed vasodilator. While going through open evidence to search information regarding hydralazine, a 2011 Cochrane systematic review found no randomized controlled trials comparing hydralazine to placebo for essential hypertension. Hydralazine lowers blood pressure through direct relaxation of vascular smooth muscle with a preference for arterioles over veins by interfering with calcium movements within vascular smooth muscle. Adverse reactions include headache, tachycardia, palpitations, angina, peripheral neuritis, blood dyscrasias, and drug-induced lupus erythematosus. Contraindications include coronary artery disease and mitral valve rheumatic disease. Its warnings include patients with a history of cardiovascular disease, patients with kidney impairment, and patients with mitral valvular disease. It is used for hypertension, but is not a preferred agent for routine essential hypertension. Hydralazine was approved in the 1950s and is available in an oral tablet form as well as an injectable solution. It requires multiple daily dosing as often as 4 times a day. Patients on hydralazine should be informed to be consistent with food consumption when taking the medication because food enhances its bioavailability. In terms of drug interactions, we need to take into consideration medications that will have an additive hypotensive effect. Minoxidil is highly effective at lowering blood pressure. According to FDA labeling, minoxidil reduces supine diastolic blood pressure by 20 millimeters or to less than 90 millimeters in about 75% of patients with hypertension that could not be controlled by other medications. Minoxidil reduces blood pressure through direct arteriolar smooth muscle relaxation, acting on ATP-sensitive potassium channels. Its adverse effects often limit its use. Cardiovascular effects include reflex tachycardia, pericardial effusion, occurs in about 3% of patients, especially those with renal impairment, and we also see abnormal ECG changes. Hypertrichosis is nearly universal and occurring in about 80% of patients. Fluid retention can be severe, which occurs in about 7 to 10% of patients. Its contraindications include pheochromocytoma and hypersensitivity to its formulations. Its warnings include recent myocardial infarction, heart failure, and patients with kidney impairment. Its FDA-approved indication is for symptomatic hypertension or hypertension with target organ damage not manageable with maximum doses of a diuretic plus 2 other antihypertensive drugs. Minoxidil was approved in the 1970s and is available in a 2.5 mg and a 10 mg oral tablet. Its initial dose is typically 5 mg by mouth once a day. Dose titration should occur no sooner than every 3 days. One interesting dosing pearl is that it takes into account the patient's supine diastolic blood pressure. If the patient's supine diastolic blood pressure falls by more than 30 millimeters of mercury, then the total daily dose should be divided rather than given as a single daily dose. Sodium nitroprusside is highly effective at lowering blood pressure with clinical trials showing it can lower blood pressure without an observed limit of effect when infusion rates are increased, but its monitoring and toxicity concerns make it unfavorable. It causes peripheral vasodilation by direct action on venous and arterial or smooth muscle. It interacts with oxyhemoglobin to produce methemoglobin, cyanide, and nitric oxide. It works by interacting with oxyhemoglobin to release nitric oxide, which activates guanylate cyclase, which increases cyclic GMP, lowers intracellular calcium, and produces rapid vascular smooth muscle relaxation in both arteries and veins. Common side effects include headache, flushing, lightheadedness, and orthostatic hypotension. Its contraindications include its use in eclampsia or preeclampsia, patients with inadequate cerebral circulation, patients with congenital optic atrophy or tobacco amblyopia, and intermittent use of PDE5 inhibitors. The warnings include cyanide toxicity, a box warning for hypotension, increased intracranial pressure, methemoglobinemia, and thiocyanate toxicity. Its clinical use is the treatment of emergency hypertension and acute decompensated heart failure. Sodium nitroprusside, which from now on I'll just refer to as SMP, was approved in the 1980s and has a brand name formulation for its ready-to-use vials called Nipride RTU. The ready-to-use vials are available in 0.2 mg per ml or 0.5 mg per ml concentrations in 100 ml vials. It's also available in a 25 mg per ml concentration, which requires dilution prior to administration. Its initial dose is 0.3 to 0.5 micrograms per kilogram per minute via IV infusion and can be titrated every 5 minutes to a maximum of 10 micrograms per kilogram per minute. Its onset of action is under 2 minutes, and its hypotensive effect is short-acting, ranging from 1 to 10 minutes, hence the need for infusion. It's highly sensitive to light, and its container should be covered to protect it from decomposition due to light. Its natural color has been described as either a clear colorless to a faint brownish pink color. Any particles present in the container or if the medication exhibits a bright red, green, or even blue color are signs of decomposition and the product should be discarded. Renal and hepatic impairment increases the risk for toxicity. Its drug interactions include PDE5 inhibitors, riociguat, and primaquine. Why are headaches, palpitations, and angina possible side effects of hydralazine? These side effects primarily occur due to baroreceptor-mediated reflex sympathetic activation because of arterial vasodilation. When arterial pressure falls, baroreceptors located in the carotid sinus and aortic arc experience less stretch and fire less. This leads to increased sympathetic outflow, reduced parasympathetic tone, and increased norepinephrine release. The result is reflex tachycardia, increased cardiac contractility, and increased myocardial oxygen demand, which helps explain palpitations and angina. The headaches likely occur because of cerebral arterial vasodilation combined with an increase in blood flow to the cerebral circulation. Because of these reflex-mediated effects, beta blockers are often used with hydralazine to blunt tachycardia and reduce myocardial oxygen demand. Hydralazine has been associated with peripheral neuritis. This typically presents as paresthesias, which are abnormal sensations, numbness, or tingling, and typically affects the distal extremities. This is likely related to an antipyridoxine effect, leading to functional vitamin B6 deficiency. Vitamin B6 is essential for normal peripheral nerve function, and a deficiency affects sensory nerves. A JAMA review on peripheral neuropathy identified hydralazine as one of the medications that can cause B6 deficiency, leading to neuropathy. Evidence is limited, and routine prophylactic supplementation is not clearly standardized. If drug-induced peripheral neuropathy develops, B6 supplementation may be added. Hydralazine is well known to cause drug-induced autoimmune syndromes, including drug-induced lupus erythematosus, and more rarely, anti-neutrophil cytoplasmic antibodies associated vasculitis, or simply AAV. Some studies cite that 7 to 13% of individuals taking hydralazine develop drug-induced lupus. Because hydralazine can also cause hematologic abnormalities, patients should have a CBC and an anti-nuclear antibody titer performed before and periodically during therapy, even if the patient is asymptomatic. A positive ANA alone is not diagnostic of drug-induced lupus because it is approximately 95% sensitive, but nonspecific. If the ANA is positive, a referral to rheumatology is likely appropriate. Hydralazine-associated blood dyscrasias can present as anemia, leukopenia, purpura, lymphadenopathy, and splenomegaly. Patients should be counseled to report fatigue, dyspnea on exertion, fevers, recurrent infections, easy bruising, or gingival bleeding. Pericardial effusion is an accumulation of fluid in the pericardial space. When fluid accumulates rapidly, it compresses the heart and impairs filling, which can lead to life-threatening condition referred to as cardiac tamponade. Minoxidil carries a box warning for pericardial effusion. Minoxidil causes significant sodium and water retention, which may be a contributing factor in the development of pericardial effusion. There has been an increase in the off-label use of low-dose oral minoxidil for alopecia. Both symptomatic and asymptomatic cases have been reported with low-dose oral minoxidil, which is usually between 0.25 to 5 milligrams, and the true incidence is unknown. A cross-sectional point-of-care ultrasound study found no increased prevalence of small asymptomatic pericardial effusions in alopecia patients on low-dose oral minoxidil compared with controls. Patients should be monitored for dyspnea, peripheral edema, chest discomfort, and weight gain. Patients placed on minoxidil for hypertension usually require a beta blocker and a diuretic to manage tachycardia and fluid retention, especially with higher doses. Minoxidil can cause ECG non-specific T-wave changes consisting of flattening or inversion, which, depending on the reference that you look at, occurs in about 60 to 90% of patients. These ECG findings are important to recognize because T-wave inversions are seen with acute myocardial ischemia and can cause diagnostic confusion. However, these are usually benign and are not associated with symptoms, heart rate changes, elevated cardiac enzymes, and persist during exercise without worsening. Hypertrichosis is a dose-dependent adverse effect of minoxidil that typically develops within 3 to 6 weeks after starting therapy. It is often first noticed on the temples between the eyebrows or near the sideburn area of the upper lateral cheek and may later extend to the back, arms, legs, and scalp. The exact mechanism is not fully understood and it involves multiple proposed pathways. With continued use, it may lessen over time in some patients. It is more common in women than in men, and after stopping therapy, it resolves within 1 to 6 months. SMP metabolism involves a multi-step process that generates cyanide. In the overall process, nitric oxide is also produced, which is involved in vasodilation. I'm going to break down the metabolism into 4 major steps. Step 1 is cyanide generation. One molecule of sodium nitroprusside reacts with hemoglobin to produce 1 molecule of cyan methemoglobin and 4 free cyanide ions. Step 2 is temporary cyanide buffering. Some of the released cyanide is temporarily buffered by binding to ferric iron in methemoglobin, forming cyan methemoglobin. However, this buffering capacity is limited. Step 3 is detoxification. Most of the cyanide produced is enzymatically converted to thiocyanate by the mitochondrial enzyme thiosulfate cyanide sulfur transferase, or simply referred to as rhodinase. This reaction is rate limited by the availability of sulfur donors such as thiosulfate. This step is crucial because thiocyanate is far less toxic than cyanide and is eliminated in the urine. Step 4 is toxicity if detox fails. Cyanide that is not buffered or detoxified binds to mitochondrial cytochromes, which prevents them in participating in oxidative metabolism and shifts cell toward anaerobic metabolism. This can lead to lactic acidosis and cell death. In the next slide, I'll review the clinical implications of this metabolism. As stated in the previous slide, the rate-limiting step in cyanide detoxification is the availability of thiosulfate as a sulfur donor for rhodinase. At infusion rates above 2 micrograms per kilogram per minute, cyanide is generated faster than the body can dispose of, especially at the maximum recommended dose of 10 micrograms per kilogram per minute. At this rate, patients' cyanide buffering capacity may be exceeded in under an hour. This is why we should limit the maximum rate to as short a duration as possible. Many references teach no more than 10 minutes. Several clinical considerations can increase the risk for toxicity with SMP. Hepatic dysfunction increases the susceptibility of cyanide toxicity because rhodonase is a major hepatic enzyme. Renal dysfunction increases the susceptibility for thiocyanate toxicity due to its renal elimination. Tachyphylaxis is usually an early sign of cyanide toxicity because cyanide poison cells cannot respond to nitric oxide-mediated vasodilation. Other signs to look out for are air hunger, confusion, venous hyperoxemia, altered mental status. When monitoring for cyanide toxicity, arterial blood gases, serum lactate, and cyanide levels can be measured, but lactic acidosis may not appear until more than an hour after toxic cyanide levels accumulate. Cyanide toxicity may be treated with hydroxycobalamin as a preferred agent. Hydroxycobalamin binds with cyanide to form cyanocobalamin, a non-toxic form of B12, while sodium nitrite and sodium thiosulfate are alternatives. Thiocyanate toxicity can also occur with prolonged infusion and may present as tinnitus, confusion, hypothyroidism, and muscle twitching, just to name a few. Unlike cyanide toxicity, it can be treated with hemodialysis. Methemoglobinemia can also occur, but it is less common. The use of sodium nitroprusside should be avoided in preeclampsia and eclampsia due to the risk of fetal cyanide toxicity. SMP crosses the placental barrier, but unlike the mother, the fetus has limited capacity to detoxify cyanide because the rhodonase enzyme system is not fully developed. Tobacco amblyopia is an older term for toxic nutritional optic neuropathy, which occurs due to tobacco smoke. Chronic tobacco use leads to ongoing low-level cyanide exposure, which may deplete or overwhelm the rhodonase enzyme system over time. Smokers have a higher baseline blood cyanide thiocyanate exposure than non-smokers. The optic nerve is especially vulnerable to further cyanide-related injury. In patients who have impaired cyanide detoxification, even standard doses of nitroprusside could precipitate acute cyanide toxicity with potentially irreversible visual loss or death. SMP also carries a boxed warning for excessive hypotension. The box warning states that it should only be used when available equipment and personnel allows for blood pressure to be continuously monitored. Infusion rates higher than necessary can lead to blood pressure so low that it can compromise perfusion of vital organs, leading to irreversible ischemic injury or death. The use of SMP and PDE5 inhibitors such as sildenafil or tadalafil is contraindicated due to the risk for severe hypotension. This occurs because of the synergistic effects on the nitric oxide cyclic guanosine monophosphate pathway. When both medications are present, there is increased production of cyclic GMP from SMP and decreased degradation of cyclic GMP from PDE5 inhibitors, which results in a large accumulation of cyclic GMP. As a related nitrate class pearl, the 2023 AHA-ACC Chronic Coronary Disease Guidelines, nitrates should be avoided for at least 24 hours after taking sildenafil and vardenafil and at least 48 hours after tadalafil. Riociguat, the brand name is Adempas, is a soluble guanylate cyclase stimulator used to treat chronic thromboembolic pulmonary hypertension, and it's also used for pulmonary arterial hypertension. Its use with SMP is contraindicated because of the expected increased levels of cyclic GMP creating a similar synergistic hypotensive risk? Okay, so the answers to the first 5 questions is 1 Bravo, 2 Charlie, 3 Bravo, 4 Charlie, and 5 Charlie. And that was your dose for medication education. I do hope you enjoyed today's video. If you did, please consider subscribing and sharing my channel. Also, feel free to leave me some feedback. I would love to hear what the audience thinks about my style. That being said, thank you. Have a great day.